It's a pleasure to see you, although indirectly. And first of all, I would like to introduce to you our panel and our moderators. So I'm Mark Hardy. I'm a transplant surgeon and a former director of the transplant unit at Columbia. And on my right is Dr. Karen Hehenberger, who is the CEO of Lifebulb and also an MD and a PhD, and most importantly, a recipient of both a kidney and a pancreas. And on my left is Brian Runge, who is the director of our living donor group of coordinators at the New York Presbyterian Hospital. We are very pleased today to have as our panelist Dr. Casey McCune, who is the surgical director of the Pancreas Transplant Program, an assistant professor of surgery, and also a very experienced kidney transplant surgeon. In the middle is Maxine Morris, who is one of our chief coordinators for kidney transplantation. And on my right is Dr. Chang, who is assistant professor of medicine and an important member of our transplant nephrology group. They will be answering most of the questions while we will be asking the questions. So we will start, first of all, with the topic for today is preparing for kidney transplant surgery. And so the obvious thing we have to know first is, what do I have to do while waiting for a renal transplant? This assumes that you are already on the waiting list, and that part of the course and the questions have been answered in the previous sessions, which you can acquire by going to Lifebulb and get it from the archives. So there are already previous 4 sessions on these subjects. So we start with, what do I have to do while waiting for a renal transplant? So let me just start with Brian. Oh, I'm sorry, not Brian, with Maxine. What does the patient have to do while just waiting around?
Okay, thank you, Dr. Hardy. So when a patient is approved to be actively listed for a transplant, they first attend a class to learn more about what to expect while active on the kidney transplant list. And some of the things include that they are expected to keep up with their primary care with their primary physicians. They need to inform us about any changes in their health, any medication changes, any testing that they do outside. We need to receive the results. If they are hospitalized, receive a blood transfusion. If they develop an infection and they're on antibiotics, they need to let us know. Also, if there are any changes in their name, their address, phone number, their contact information, if they start dialysis or there's a change in their dialysis center, they have to reach out to us and let us know.
That's very good. Any additions? Dr. McCune, anything else you'd like to add?
I think that's pretty comprehensive. Depending on the patient, depending on if you've started dialysis or not yet, there'll be other things we ask of you, how frequently you have to come see us to make sure nothing's changed, how frequently you need to see a cardiologist and those things. But most importantly, if anything does change, you end up in the hospital for one reason or another, we're kind of like your extended family. We should know so that we can make adjustments for what we need to look into, make sure you're healthy enough. What can we do to optimize you for surgery? Have things changed? What do we need to do? And we don't know that unless you give us a call.
So Dr. Hardy, I wanted to jump in a little bit here. I first of all, welcome everyone. As Dr. Hardy said, I'm Karin Hemberger. Wanted to just make sure everyone understood that this is featured on transplantlife.com, not on Lifebulb. So if you wanted to go to archived versions of previous sessions, that's where you go, www.transplantlife.com. And you can access that. And again, I just wanted to welcome the audience, all patients, care partners who are interested in this topic and in the transplant process in general, because our members here are incredibly knowledgeable. So please do ask questions, put that in the chat or contact anyone in the Lifebulb team, and we can get those questions to our esteemed panel. So with that, I just wanted to add one thing to what Dr. McCune and Maxine said, was that as someone who's gone through this, keep in mind also the family, because if, for example, someone in your family gets sick, or someone in your family, in my case, for example, someone was going to travel and got vaccinations, those things can also be important to your own care. And so just keep that in mind, because it can influence you indirectly, but it can be very important for the transplant. So it's not just about you, it's about everyone in your household.
And I can add on to that. Actually, to maybe round this out, your coordinators are your best friends. Will we, myself, Maxine, 8 or 9 other of our coordinators, will take that information. Thanks for telling us that you want to get a vaccine, or somebody you're close to getting vaccinated is or is sick, because we can then help you through and maybe get further records if for some reason you're sick, or educate you on maybe staying away from certain people at certain times. So your coordinator can either take it that way, or if it's unnecessary, no sweat off our shoulders that we talked. You stay on top of yourself by also communicating with the coordinators.
All right, very good. So let's go on now to the issue of what is the operation like? How do you get called in and then you have an operation? And why don't we start with Dr. McCune, who does these operations?
So usually what happens is you're on the deceased donor list. It takes time for you to come up to the top. But when you're in the top, we start putting 5 people in for every kidney, because we don't know what's going to happen. Number one, the person who's number 1, they might be ill that day. They might have a pneumonia, something like that. Number 2 might react to the kidney. So we talk about cross match when we check to see if you match the organ. So we put 5 people in every time. So you may get phone calls before you're number 1. You'll get a phone call just to see if you're interested first. We check your match. When you do become the person that is what we call primary, or that kidney is yours, we're going to call you back. And in that conversation, we're going to have a plan for you. So whether you need to come in, whether you need to figure out dialysis, exactly what happens from there. You come into the hospital, you meet your anesthesiologist, they talk to you about surgery. You meet one of us, the surgeons, we talk to you about surgery. They take you back and get you off to sleep. The surgery itself takes about 3 to 4 hours. During it, you keep the kidneys you were born with. This is an extra kidney, and it's gonna go down in your lower belly by your hip bone. And the incision kind of looks like a half moon. And hopefully when you meet one of us surgeons, we'll show you exactly where yours will be. We connect 3 things. We perform the surgery. Again, it's about 3 to 4 hours. Most people are in the hospital somewhere between 4 and 7 days. Most people don't eat right away. They're usually hungry kind of the next day. We make sure your pain's well controlled. We start adjusting the medications you come in on, plus give you new transplant medications, which we'll teach you about while you're in the hospital. And that's kind of a summary.
Jae, anything to add?
Yeah, I mean, I think Dr. McCune pretty much said everything, but from a nephrology perspective, I think it's very important that you continue your dialysis as you're doing, because in case because you have to be optimized for the surgery. So in case you for some reason miss dialysis, then you don't want to be undergo the surgery while you're volume overloaded, or you have your electrolytes are not normal, so that may push back the surgery. So I think it's very important that you no matter what, you continue your dialysis schedule as you're doing. Don't skip or miss anything. And if in case you're sick and or for some reason you miss it, just update us just to make sure that everybody is on the same page.
Jay, what happens if the kidney doesn't work right away?
What
It happens in about, with deceased donor kidneys, it happens in about 40 to 50% of the time.
Exactly, yeah, up to 40% of cases that can happen. But it is not unusual, and you have to imagine, obviously, the kidney will come, will be in the ice and it will be shipped over. So it is under the shock of the ice. So it has to wake up, and as Dr. Hardy said, up to 40% of cases, it may not work right away. If that happens, obviously, you will be monitored on a daily, regular basis about your blood work. We will examine you. We will monitor your blood pressure, heart rate, and everything. And then, in case you need any dialysis until the kidney starts to work, then we will provide you with dialysis. In case you don't need any dialysis, obviously we're not going to dialyze you. But again, up to 40% of cases it can happen, so it's nothing unusual. But until
in
in
case of a living donor, we got a question from our audience. How often does it not work immediately in the case of a living donor?
Casey or Jade?
Anyone.
Casey, go ahead.
It's very rare for a living donor not to work right away. We say kind of in the realm of 1 to 3% of the time. And usually if we think it could be that type of case or there's risk factors, we're telling you beforehand, but it's very, very rare that somebody needs dialysis after a living donor.
So I'll give you my case just because I had that. I had a living donor, and my kidney that I got from my father didn't work until the 3rd day. So it was pretty scary. But in the case, it was Dr. Ratner. He was very confident that it would kick in, but I think maybe behind the doors he wasn't as happy about it. I heard afterwards that it was very close to putting me on dialysis, and I had not had dialysis. So that would have been the first time I would be on dialysis. So it can happen, but very unusual. Yeah.
There's a lot of ultrasounds like every day after that.
Yeah, it's 13 years later and it's still working. So it took 3 days, but kicked in.
Yeah. Any other questions? Any other comments?
It's extremely important to sort of piggyback off what Dr. McCune was saying. It's very important that you have a transportation plan in place ahead of time. And this has to be private transportation for coming to the hospital for your transplant, going home, and coming in for your frequent post-operative visits. Public transportation is not allowed because that puts you at risk for infection. So whether you have a family member that's bringing you in or you coming in by Uber, but you must have a solid plan that's in place. And this should be a plan that's available before you get called in, and not waiting until you're called in and now you're trying to figure out, well, how am I going to get to the hospital? So that's extremely important.
Jay, can you tell us when you can start taking public transportation? When do you think you should be able to take public transportation?
I mean, basically, the concern is, the concern is that, infection, right? So, you will, in the beginning with the transplant, I think you may not notice it, but you will get, 2 very strong intravenous medications, so that it will basically kill all your white blood cells, which is, important for the immune system. So I think, you should not take public transportation in the first few months, I think, until you recover from that. Make sure that you wear a mask and wash your hands well. So
is that thymoglobulin, Dr. Chang?
Yes.
So that is only for about 3 days, right? After kidney transplant?
Yeah, you will. Yeah, you will get, starting with this, on the day of the surgery, you will get a total of 4 doses.
But the effect of thyroglobulin is about 15 to 30 days.
So that's important to notice. So that's about, say, 3 months, you would be okay? 2 to
Oh,
3
yes.
months.
Yeah, I think so.
I think even earlier, but it varies. But I think that the most important thing that one has to be aware of is actually using all the COVID precautions. It's you wear a mask and you wash your hands well, wherever you're in any crowds.
Talking about pills, person from our audience asked, after the transplant, how many pills do you normally have to be on? How many different, I guess, not maybe per pill for a regular not counting the ones that you were on before?
I can do this one.
Yep, thank you.
I tell people there's 3 categories, and then we can go how many pills of each. But when you first go home, there's surgery pills, so a pain medicine and a stool softener, anti-infective pills. So like Jay was alluding to, there's certain things to help prevent infection. For most people, there's 3 different medications for that. And those fall off at kind of 9 months to a year after the transplant. And then anti-rejection meds, which are the 2 medications you'll take as long as the kidney's functioning. So again, when you first go home, there's like a whole bunch that you're taking, and then it'll end up paring down to just 2 medications, usually twice a day, for as long as the kidney's working.
And you also, of course, have to take the pills that you took before. Frequently, the pills you took before, some of them fall off. So after a short time, you don't have to take folic acid and a few other things, but your antihypertensive pills generally stay. Your heart pills generally stay.
And what about omeprazole? When you take so many pills, is that a common add-on?
Most people.
Go ahead, Casey.
Yeah, most people end up on something like that long term. And then kind of dovetailing with what Dr. Hardy's saying, things like binders will go away. Most people don't have gout after a kidney transplant once the kidney's functioning, so those kind of meds go away. Sometimes people who are on 3 antihypertensives will come down to just 1, but this is something that happens over a couple months. So part of the reason you see us so frequently, so twice a week the first month, once a week the second month, is for us to adjust your old medications as well as adjust your new ones. So it's important to keep track of what's going on during that time period so we can help it out.
Yeah, I want to mention also that there's going to be a lot of changes in the beginning, of the medication. Also, those of, one of the anti-rejection medication called tacrolimus, it's based on the level we give you out. So, and there's going to be a lot of changes depending on, what the level is. So don't get surprised or don't get, discouraged, or, if we check often and if we have to adjust the dose many times, it's not your fault. It's just a, regular body's response. So, but with the time, I can't get frustrated because, you have to go up and down the dose very often, but then with the time, it usually levels down and we know your body and you know your body so that, it will stay at the same level. So it's going to be a lot of visits, but the good thing is also, there are so many doctors and, coordinators and even pharmacists, monitoring you closely. We all work together so that, everybody helping you to make sure that you're on the right medication, the right dose, and, that you understand why you're taking this and that.
So while you're at this subject, one of the issues is obviously the side effects of some of these drugs that our patients worry about. So can you start out, Jay, and you were talking about tacrolimus. That in itself can cause some problems that initially can appear and then disappear after we readjust the doses.
Yeah, tacrolimus is a very helpful drug, but also a weird drug which is basically protecting you from rejection of the kidney. But as Dr. Hardy mentioned, it can chronically in long term, it can cause also some damage to the kidney as well. So, and then also it does have, some side effects, especially, common is like, you get shaking in your hands. Sometimes it can be really significant. You can get headache. Sometimes you can, get anxious. It can also, raise your blood pressure or make your diabetes worse if you have diabetes. So
Can this happen right? Can this happen right after the transplant?
Well, right after transplant, we usually there's so many.
Within a few days, can you start shaking suddenly?
You could, I think you could.
Yeah.
Yeah, but I mean, obviously, as I said, the damage to the kidney, that's a more long process, and also
That's more like 10 years, isn't it?
Yeah,
It's a
exactly.
long time.
That's one of the reasons also why we check you so close in the beginning, along with the blood draw, because we obviously we don't want to overdose you, which may increase the risk of side effect, but also not underdose you, which may cause rejection. So we know where the sweet spot is of the drug levels. So that's one of the reasons why we check you very close in the beginning, check your blood work very closely, so that you have you in the right dose. And yeah.
So if you're at the right dose, generally you don't get the shaking, you don't get the headache. And if you get the shaking, you can usually lower the dose and it goes away.
Dr. McCune wants to say something.
Say something.
One nice thing though about transplant, and then in this day and age, is we have a lot of options. So in general, people do have side effects, and if you Google these drugs and those kind of things, you'll see a lot of different things. Is we can usually shift you to something that works best for you. So when you first go home, we put you on the things we know works best for rejection, but maybe they don't work the best for you. For example, I had a guy with the shakes that they're talking about, but he was an electrician. So that was completely not tolerable in his life. So we switched him to something else. So ultimately, long-term, we'll find the right regimen for you and minimize the side effects no matter what it ends up being.
That's great. So there are a lot of good drugs out there in the transplant space.
Yeah, exactly. I think it was very important from Dr. McCune to mention that there are alternative medications. We have other choices. It's not like you get a side effect. I'm sorry, you're done. You have to live with it for the rest of your life. No, we do have nowadays alternative medications.
So one alternative to tacrolimus, or I call it tacrolimus, but maybe that's wrong, is belatacept. One of our audience members is asking about belatacept. Is that something Columbia recommends?
Some of us do.
Yeah, currently, the standard of care right now here at Columbia is that we do start with tacrolimus or tacrolimus, but we do. I have many patients who are on belatacept. Yes, in case you develop side effects of tacrolimus, yes, we do offer belatacept. Yes, which is a once-a-month infusion. Which some people think is convenient. Some people don't like the idea to be, kind of having to come here once a month for the rest of their life. But yeah, we do offer belatacept.
So now let's go back to the fact that the patient is coming in for a transplant. How fast do they have to get in here to get a good kidney? In other words, what is the interval that the kidney can be kept around for them to arrive here? Casey, can you comment on that?
I will also say that in addition to our participants commenting over here, there's a Q&A thing where another individual has been asking about live donor versus Ketovaric.
Please go ahead and answer.
Okay, I'll answer that one first then. So when cadaveric donors, again, are donors that come from a deceased individual. So they have gone through the death of their previous owner, have been transported to us, and then have been transplanted into you. So when we talk about cold ischemic time or time on ice or those kind of things, these are the ones that tend to have a little bit more time because they've had to travel to you. These are also the ones that it's highly variable, the quality of these organs. Sometimes they range from about 7 years of graft life to up to 15 years with an average of around 10. Whereas living donors tend to be more of a consistent idea of about 20 years of graft survival. The living donors, you come in with a living donor more often than not, this surgery happens kind of at the same time, and the operating rooms are adjacent to each other. So when the living donor kidney comes out, it comes around to your operating room and then goes into you. And again, they tend to last a little bit longer and work more quickly. So we talked about living donors tend to work right away, whereas deceased donors about half the time. People may need some amount of dialysis afterwards. I hope that that answers.
So the mechanics of that, because we are talking about the surgery, and we did have a question in the beginning about this, the time between the donor surgery and the recipient surgery. You're saying that they're in adjacent operation rooms, but you start with the donor, I would assume.
Yeah, we stagger them more so to make sure everything gets off to a nice clean start in one room, and to decrease how long the recipient is under anesthesia. So usually the recipient case starts about an hour after the donor case. However, there are programs in the United States where living donors can give somewhere else in the country and then also have them shipped with a very high quality kidney and outcome. But generally at Columbia, we tend to do it within our center. So it's usually done at the same time in adjacent ORs.
So there is a question about whether we participate in any clinical studies using stem cells. We do not in relation to organ transplantation, not yet. There is a lot of experimental work on it, and there is actually a protocol about tolerance induction, but it's very rare in organ transplantation. Whether the idea of other stem cell transplants is appearing more and more, and toward some of the last meetings of this symposium around July, August of the coming year will focus actually on stem cells. So we won't elaborate on that at this moment. But the simple answer is no, we are not using stem cells for organ transplant. And now in terms of organ preservation, if you keep the organ for a while and cold, what does a while mean? Can I arrive there 24 hours later after I get cold if I'm on vacations in Florida? Dr. McCune, can I do that?
Probably a bad idea. However, kidneys we can keep on ice or on a pump or preserved, sometimes upwards of 55 hours we've done at Columbia, but it's not the ideal situation. Every hour the kidney is on ice could be bad for the kidney and could be bad ultimately for you. So we try to get them in as quickly as possible. And some of that is a little bit more complicated than just saying how long it's been on ice, right? If it's a high quality kidney, we may extend that envelope a little bit more. Whereas if it's a marginal kidney, we may say, no, this one really has to go in quickly.
So what does marginal mean? Does it mean older donor? Does it mean a kidney from somebody who may have had a little hypertension or maybe a little diabetes, a touch of diabetes?
I'm suspicious Dr. Hardy knows the answer to his question. But generally speaking, a young healthy donor tends to be less than 65 and does not have diseases that could affect the kidney. So diabetes, high blood pressure, maybe somebody who died of a stroke, those kind of things would affect the kidney. In transplant, we actually have a score that we use now. That's a big complicated equation that puts all those things in. And the score kind of goes like golf. So the higher the number, the worse the kidney. So kind of 85 and above represents those older kidneys with diseases that could affect the kidney. And then 85 and below for this score tend to be healthier kidneys that we'd expect to last longer and could tolerate a little bit longer cold time.
Does your algorithm also include a biopsy of the new kidney, or is it merely based on the symptomatology and the donor's diseases?
No, that's a very good question. The answer to it's no.
So
The answer is the KDPI does not include a biopsy, unfortunately.
There are 10
But the
points.
biopsy may be quite good. And
There are 10 points to calculate the KDPI score, right?
Excuse me?
There are 10 points, 10 categories to calculate the KDPI score, and you can actually Google and then do like KDPI. It's fun to do. You can Google KDPI score, and then there's like a calculator there, and then you can punch in whether the patient, as Dr. McCune mentioned, whether the donor, potential donor had diabetes, high blood pressure, hepatitis C, the age, cause of death, and so on. It calculates, gives you the number of the percentage. But
No,
it does
the reason I'm asking
it
is
does
that-
not include the biopsy result. Yeah.
Now, the reason I'm asking, I think it's interesting because some people live a life of, indulgence, if I say it kindly, and then some people live a life of being very healthy. But those people with the indulgent lives, they sometimes live until they're 100, like the French. And then some people who are not so, are very healthy, they may die or have lots of issues early on. And so, maybe the organ doesn't always reflect the lifestyle. So it's interesting if that score doesn't include the actual organ function.
There's also a lot of literature and debate about the utility of the biopsy, right?
And the biopsy is only from a small portion, maybe reflecting the glomeruli.
Yeah, and then also it's not like really full evaluation. It's a fasting, it's a frozen sections, and so it's not, as you said, it doesn't represent the whole kidney. And there's a lot of debate, a lot of literature, pro and con, about utilizing the biopsy, to decide about the organ quality. So.
We have a specific question here. I'm sorry to have taken time from our audience. I am O positive and concerned about finding a living donor. I know about swaps, but is that likely for someone like me?
I can start with that.
You can take it out. Brian?
So anything's possible. It's how difficult each scenario is, and scenarios meaning blood type matchup between the recipient and the donor. An O recipient, the positive, just real quick, the positive, negative on your blood type, we don't even look at that. We look at the O, A, B, and B. If you're an O recipient, it's very difficult because you need an O kidney. You can possibly, there are scenarios where we can look at, well, maybe if you have only an A donor, that's your only shot at a living donor is A, we can look at certain titers. But if we're talking strictly swaps, if you have an A or a B donor, or even an AB donor, it's very difficult. And then we let our recipients and donors know up front that that's going to be difficult, but we can try. What else can you do other than go on the deceased donor list in the meantime? We can try and maybe get a swap with this living donor. And if you're going to rank them, and Dr. Hardy or Dr. McCune, you can comment on this, but if you're an O, a B donor is okay. A is getting a little harder to, get more difficult to swap. An AB donor and an O recipient is very, very, very unlikely.
Now, Brian and Casey and Jay, maybe you can answer this. I never quite understood why an O is so difficult. Because if you have a husband who wants to give to a wife, the wife frequently has antibodies against the husband, and the husband may be an O. So why can't the business of husband-wife swaps work more often? Anybody answered that?
I don't think it happens as much as we need it to, considering how many O recipients we have. It's just
It's a matter of numbers, you think?
It's a matter of numbers. It's the most common blood type, and they can only accept from O. It's just, yeah, when that happens, it's really nice, but it doesn't happen enough.
You have to remember that when a donor and a recipient, and a donor especially, comes forward, and we call them and let them know they're a match to their intended recipient, that sets off a lot of stuff going on mentally. Like they're excited and they want to come forward. And then if you say, okay, yeah, you can donate to your intended recipient, but also here's these swaps that you could also not only help your recipient, indirectly, you can help others. So not only are you getting one person transplanted, maybe 2, 3, 4, 5 with that kind of blood type, but they're already on the route sometimes of, I want to donate to my intended recipient. Again, it's all in how a lot we present these things, and you can, it's not convincing somebody to swap, educate and tell them, boy, you could help other people out. And some people do come forward and do those kinds of swaps and help multiple recipients out, and those donors then pay it forward.
Can I say we have another FDA.
Yeah, sorry, I just wanted to, you were talking about the Hep C question. Yeah, I just wanted to ask Maxine a question, if I may. During this process of preparing for surgery, we've talked a lot about the mechanics and the medical portion. What about the mental health portion? I mean, are patients being offered that kind of support as well? Does that part of the overall team?
Well, as you can imagine, being on the wait list, you don't know, the patients don't know when they're going to get called. So it does cause a lot of anxiety. But one of the things that we've implemented now for about a year, one of my colleagues, Carly McNulty, is an educational session called All Set. And these sessions are given every month. They cover different topics about transplant. And we really get a really good attendance. And it's an opportunity for the patients to ask their questions, whatever questions they may have. And I think that really, really, really helps a lot, because sometimes when they're active on the list, we probably may only speak to them a couple of times a year. With this educational program that we have, now, we get to speak, they can communicate with us at least, once a month during, this group educational session. And I personally have seen where it's really lessened a lot of the patient's anxieties, so I think it's a good thing. But, the anxiety.
So the educational session is similar to this one. It's, I guess, but I was thinking more about personalized, treatment. Maybe you have a social worker or a mental health professional, someone who could be offered to that specific person.
Definitely. So
yeah.
If we, run into a patient where, they're really having a hard time, we ourselves can talk to them. Sometimes that does help. Otherwise, we can always reach out to our social workers and, let the social workers know, this particular patient is having a hard time, let them know the details of it. And our social workers are really awesome. They will reach out to the patients and, speak with them. And if they feel that they should be referred to a therapist in the community, they will definitely help with doing that.
Okay.
So yes, the support is there for them.
Right.
So we're moving right along now. We have the kidney in place. The operation went very well. Took about 3 hours, and actually it may have taken shorter time. And now we have to worry about whether it's going to reject or not, or maybe complications. So can you comment on any possible complications that we worry about more than others? Do we do any studies, make sure that everything flows, that all the plumbing is okay? Casey.
We catch up with a couple of the questions that have been sitting just for a second, and we'll circle back.
Okay.
Someone asked, is a cadaver kidney that is Hep C as viable as not having Hep C? Dr. Hardy, do you want to answer that for us?
Is a Hep C kidney good?
Mm-hmm.
Yes, nowadays the Hep C kidney may be very good, because we do now have medications that are directed against Hep C. One of the medications cures Hep C within 3 to 6 months or so, in about 98% of the time, while another medication against Hep C will cure the other 2 or 3% that the first one doesn't cure. So essentially, we can cure a transmitted hepatitis C. We encourage our recipients to take all kidneys with hepatitis C, because they happen to sometimes come from relatively younger people. They become available to older people because there are some people who still resist taking them for the same reason that some people resist taking vaccines, which is totally illogical. So that Hep C kidneys are really very good kidneys, and I would not hesitate to take one if I needed one.
I completely agree with Dr. Hardy. Yeah, I mean, basically the whole change the breakthrough was with the, as Dr. Hodges said, there was a revolution of a treatment of hepatitis C in 2015. You know, before that there was really no good treatment for. There was no cure for hepatitis C, but now there's like 100% almost cure rate for hepatitis C. So in that way, you can also shorten the waiting time. Usually, the hepatitis C kidneys from the younger donors, so you know, it's a better quality kidneys. And I think most importantly, obviously, medicine is done, you know, with research and data, evidence-based, and there are now, you know, papers coming out, research coming out showing that, you know, I think we have now 3-year outcome, which shows that hepatitis C positive, you know, recipients of hepatitis C positive donor kidney, they do at least as good as those who are hepatitis C negative. So those recipients who were hep C negative, getting hep C positive organs, they do at least as good as, you know, those who received hepatitis C negative kidneys, if not better.
And this applies to other organs as well.
Exactly. Yeah.
The question here is whether the RH factor makes any difference, and the answer indirectly was given previously. No, it does not. That's the positive and negative. We pretty much ignore it, like Brian said before.
And then the last question that we haven't answered yet is, how do you feel after the transplant? Will you feel sick going to the follow-up appointments?
Well, who would like to answer that? Maxine? Jae?
Well, I'll tell you what I tell people when they come see me in clinic is the recovery is about 2 months. At the end of the first month, most people are about 80%, meaning they can do one big activity and then they're pretty wiped out, want to take a nap. And then at the end of the second month is really when they feel the full benefit of the transplant. So that first month, you need somebody to help you get back and forth to appointments. It would be nearly impossible to do on your own just because you're wiped out and you're coming twice a week. Again, the end of the second month is really when everything starts to come together from surgery and the kidney recovering and everything else.
So I'm sure that you all will agree that after the transplant, actually going into the transplant, you should keep on exercising so that you go in with good muscle tone and feel reasonably well. After the transplant, you should continue trying to exercise and walk around and not stay in bed and feel sick. So it's really important to start to resume normal life, or as normal as possible, and progress. This is like an athletic exercise. This is practice.
I mean, I can speak to that since I went through it. You know, I saw it as a tournament in my case, because I was playing tennis. I mean, I saw it as a big event that I needed to prepare for. I mean, unfortunately, when you are pre-kidney transplant, you're end-stage renal disease, you're not that strong. You're most of the time anemic. You most of the time feel pretty nauseous, and you're not exactly at your best. So most people do feel better after the kidney transplant, you know, in many ways, pretty quickly. As I hear, in my case, after 1 month, I was back to work, but it took time to get back fully. And I think one of my big lessons learned was that, and this is, you know, very much normal physiology, was that I was continuing to lose weight over a longer period of time, and that was not good because I was catabolic. And I think building back muscle is really important to become stronger. And as you have a new kidney that now works better with protein and can take that, you should think about the diet as well. So as I was trying to point out the mental health portion, I think the diet and exercise are also components that we need to think about for the full team when you go in to the surgery, that you have a plan afterwards. What am I going to eat? How I'm going to combat the nausea that is triggered by the immune suppressants and the other drugs. So force yourself to eat small portions, but get that nutrition. Start exercising so you don't lose more muscle tone, because then your weight will continue to fall off, which is not good in recovery, I think.
But it is also important, I can't emphasize enough, that's my peeve, is to exercise as much as you can before the operation.
Yeah.
In other words, do not let yourself go. And this is really very important. Now, as we come toward the end, really, we now put the kidney in, and I want to just touch on the issue of diagnosis of rejection, diagnosis of problems right after the operation, and subsequently in the follow-up. So I'm going to go right through the three panelists and start with Casey. So you transplanted the kidney works a little bit that same night and the next morning. What do you do now to find out whether it really is working okay or not?
Well, two things happen after we do the kidney transplant, just as our normal procedure. One is we get a biopsy of every single kidney. So we have a baseline of what the kidney looks like under a microscope. And number two, we get something called an ultrasound, which is a radiographic thing that checks how well the blood is going in and out of the kidney, so that we have these things just baseline. It also tells us if there's any kind of blood around the kidney or how things are going from a surgical standpoint. So then if anything changes, we have things to refer back to as you progress forward. And another thing that can change is how much urine the kidney's making. So as you progress along, if anything's off, we often check a set of labs, check your blood count, check the creatinine, which is one of our indicators of how well the kidney's working.
And we do that every day, don't we?
We do that every day anyway. And then if anything's wrong, we often get them all over again because we compare them to the one before. Same thing with the ultrasound. If anything's off, urine output, how you feel, those kind of things, we check an ultrasound the kidney, make sure there's good blood flow, that the urine's able to flow out. And then we kind of move forward from there. Each day after surgery, we're more worried about certain things than other things, obviously, because as you're healing, certain things are of higher risk or lower risk. So the first kind of 24 hours, we're worried about bleeding or how well the kidney's plumbing is hooked up, so the blood vessels and those things.
So how do we know that the patient is bleeding?
We check the blood count and we have an ultrasound to show us if there's kind of blood around the kidney. As days progress on, we become less concerned about bleeding because you've made it kind of far out from your surgery, but we're more concerned about things like infections, like urinary tract infections, pneumonias, those things. So anyway, as each day goes on, we check you and we check your labs, your vital signs, those things, and it kind of tells us what to be concerned about and what's actually going on.
So before you send the patient home, how do you know that they're not rejecting? Jay, why don't you take that on? How do I know that I'm ready to send the patient home at 5 days? How do I know that they're not rejecting?
So obviously we're not gonna, we will make sure before you send you home that your kidney is getting better, right? That your creatinine is coming down, right? So if the creatinine comes down,
and if it's not coming down, what do you do?
Well, if the creatinine comes down nicely, then our suspicion for rejection is low, right? So we don't have to worry about it. If the creatinine doesn't come down, obviously, you have to see the whole picture, right? If it was a kidney which, had to be on the ice for a long time, who the donor was, then if there's a, plausible reason for it to be a little bit sleepy, then we, tend to watch a little bit longer than if it was a, kidney which was not that long under the ice, then, from a so we call good quality kidney, then we tend to be more aggressive and more suspicious and to look for rejection. So the way the definite it's basically the blood work and the ultrasound guide us to make sure that there is to guide us what may be going on, but the ultimate diagnosis to rule out rejection would be a biopsy.
And does that hurt?
Does it hurt? So it's a procedure, and it's a bedside procedure. So I get a lot of questions, when we want to do the biopsy, does it happen in the OR, in the operating room? Am I under the general?
So when do you give us the answers?
The answer is no, it does not. I mean, obviously, it's a needle pick, so we will give you lidocaine and skin, but it does not hurt, and it does not hurt in general after the procedure as well. It does not hurt.
So it's a big intravenous type. It's a needle like a big IV.
Yes, it's a needle, a pick, and then basically you
It hurts a little bit, Dr.
What's
Chang.
that?
A little bit. It hurts a little bit. I
It
gotta
hurts a
say,
little bit.
it
Yeah,
hurts
we
a little
visualize
bit.
with the ultrasound, the
And I'm a
kidney, and
Viking.
at the same time we, give lidocaine. Usually the most painful part is the skin prick, when we give you the lidocaine. That's the most part where patients say it hurts or it burns. But then afterwards we make sure that the skin is well numbed. So pretty, yeah, that's usually the most.
How long does it take to get the answer?
Usually it takes like at least 24 hours. So what happens is when we get the the kidney pieces, then we give it to pathologists who basically cuts the tissues in the tiny pieces, and then they stain it and leave it overnight to stain the tissue, and then the next day they have to wash it. So it's a lot of procedure. So and then after 24 hours they start to look under the microscope. So it takes at least 24 hours to get.
So you get an answer in 24 hours, and then if it's positive, you treat the patient. If it's negative, you send them home. That's good, or more or less. So the question comes up is, will biopsy cause bleeding from the kidney? Yes, it causes a little bit. Most of the time, it's not significant. Every once in a while, it is significant, but it's very rare. What is the incidence about, Jay? It's about.
I can give you the number. So the number reported is that in 3% of cases, so 3 out of 100 cases, you do see some blood in the urine, but it usually goes away without needing any intervention or blood transfusion. In 1 out of 100 cases, so 1% of case, the bleeding may be significant enough for you to need blood transfusion.
Okay.
And there's also the question, what creatinine level or GFR is optimal for a preemptive transplant? Obviously, it will depend on what you go into and what creatinine you go into with preemptive, but also it depends on how old is the donor and so on. But generally speaking, what do you say, what will be the optimal level of a living donor kidney transplanted into preemptively into a recipient?
I mean, you can be listed, when you hit below 20 of 20. In terms of living, obviously you don't want to wait too long that you're too sick, right? I mean, obviously.
So between 10 and 20.
Yeah. So nobody wants to, you have to be healthy enough to undergo surgery, so you don't want to wait until you're too sick, right? And in that case, you would have to even start on dialysis, so, before you get the transplant. So you don't want to do that.
Okay. I think we have answered our questions, and we could answer many more questions. We have great panelists here and moderators in Brian and Dr. Hardy. So, but we do need to finish the seminar. Dr. Hardy, if there's anything you would like to say.
No, why don't you finish?
Okay.
I think that we have finished pretty much our questions. And I think that I just want to emphasize, now that I didn't want to say anything, I want to emphasize what was started with. It is critical, really, when you get on the list, to keep the unit informed through the coordinators of everything that is changing in your life, which really means not only concerning the kidney, but your general health, any admissions, any infections, any change in addresses, all those things that were mentioned. I'm just repeating, but I think it's very important that you remember to do that, because it does affect how we call you, when we call you, and how successful we are in reaching you. So that's very important. The other thing is I want to emphasize is keep in good shape before the operation, because that way you'll come out in good shape after the operation.
Yeah.
Why don't you finish, Karen? And
I think you said it very well. On the practical side, I think it's really critical. But from a patient perspective, being in as good a shape that you can be. I mean, again, contingent upon your condition, because you don't want to push yourself too hard either, so that you get hurt. But I want to make sure that it's not just your physical health, but it's also your mental health. You're going through something that is going to be very big. Our participants here are doing this every day. You know, they're doing it, and for you, it's maybe once or twice, and it's going to be for many the first time. It's a very big procedure, and it's a big event to receive an organ from someone else that will help you survive and live better. And that is psychologically, you know, a big deal. Someone is giving you a kidney, either someone who's alive or someone who has died. So I think that preparing for that, being mentally very strong, as well as physically strong, you know, is my advice as someone who has gone through it, and also now studying others who are doing it. Those who are successful, you know, are prepared, and then also have a good team around you. And then, you know, that is a care partner team, meaning having a spouse, a partner, a friend, a child, or parent, whatever the situation is. Do not hesitate to ask for that help, because you're going to need it. And again, including the transportation, that can be paid for, of course, but it's also good to have someone to hold your hand and to be there for you when things are tougher, because it's going to be up and down. It may not be a straight line. It may not be totally easy all the way. I think you got to prepare for that.
Particularly early on.
But it's going to work eventually for most people. It's a very successful procedure. I think that's something that we may have not emphasized. This is most of the time a very successful procedure, and it's very rewarding for, as I hear it from the surgeons, to be doing kidney transplants. So anyway, thank you so much to our panelists, our moderators, and of course to the fantastic audience in how you've engaged with us and asked questions, and don't hesitate to continue to ask questions, because we are available, and this archived version plus portions of it will be featured going forward. So thank you so much.
And we will answer your questions as you mail them in. So that please don't hesitate, and I invite you to join us again on April 20th, again at 5 o'clock. And at that time, we will discuss post-transplantation surgery. How do I manage my new kidney? So we'll repeat some of the things we said today, and we'll go on from there for the long-term follow-up, and what it implies, and what is expected of us, and what is expected of you in terms of keeping that kidney moving along for years to come. So thank you very much to everyone, and I look forward to seeing you on April 20th.
Thank you.
Thank you, Casey,
Thank you.
Maxine, Jae. You were great. Thanks.
Thank you for
Thank you for having us.
having us.
Right.